So good afternoon, everybody. Thank you very much for being here. I'm very excited today to present Anders Oldfors. Anders Oldfors is a professor of pathology, specialized in neuropathology with a very, very long-standing expertise in myopathies. And today he will talk us about glycogen and lipid storage myopathies. So thank you very much, Anders, for your webinar, and we are ready to listen to you.
Thank you very much, Eduardo, and hello everybody, and welcome to Gothenburg and my office in the Department of Pathology. Cold weather here today, -6, but otherwise fine. So my disclosures are none, in fact, but there are some illustrations from this muscle pathology book. So the topic is glycogen and lipid storage myopathies, and muscle tissue may be affected by disorders of the glucose and fatty acid metabolism, since the energy demands are rather high in muscle tissue. I will give a general overview of the different diseases and focus on histopathology and some special features that may be useful as clues to diagnosis. And I will mention a couple of new diseases also in this field. So the glycogen storage myopathies are in general due to defects in glucose metabolism, the glucose breakdown to pyruvate, or glycogen metabolism, either the breakdown of glycogen or the synthesis of glycogen. And to the left you see a table of the so-called glycogen storage diseases that affect skeletal muscle. And this classification is given in this table is according to Omin classification. So it starts with type 0 muscle and down to type 15. I will not go through all of them, but a few of them. So I will start from the beginning. That is type 0 muscle, and it's called type 0 because there is no glycogen, and there is a liver type 0 also. So this is a glycogen synthesis disorder, and the main clinical effects are exercise intolerance, and some patients may have cardiomyopathy. This is quite easy to diagnose if you do a PAS staining because it's completely empty, the muscle cells, if you compare to the controls. And this is due to the lack of glycogen, as you can see in the electron micrographs here, the black dots that are glycogen granules in the muscle, which are located, in the intermyofibrillar space. So I will not say more about this than I will continue to the next glycogen storage disease, that is type 2, Pompe disease, which is, of course, much more common. And there are different forms, with a more severe infantile form, and there's an onset in child or adolescence, or the adult onset forms. And this is a disease that is not really a glycogen storage disease, but rather a lysosomal disease, because the storage is within lysosomes. So it's in the group of so-called vacuolar myopathies, where you in hematoxylin eosin staining show these seemingly empty vacuoles, but they are not empty, and these are to a great extent enlarged lysosomes, which you can see if you do an acid phosphatate staining, which stains lysosomal red, and you can see the increase here compared to what is normal. There's no illustration what is normal here, but there are some muscle fibers without this staining, and only see a few dots normally in the muscle tissue of this acid phosphatase. So this is an important staining to do if you do muscle pathology, because you can easily miss the increased occurrence of lysosomes in milder cases of Pompe disease. So in this case, for example, in hematoxylin eosin, it looks rather normal, and if you do the acid phosphatase staining, it becomes obvious there is something with the lysosomes here. Increased amounts and increased size of the lysosomes. And this is because in Pompe disease, glycogen is accumulated in autophagosomes and lysosomes, which you can see in electron micrographs as black dots, but they are filled with glycogen. And eventually these lysosomes, when they enlarge, they rupture and cause degenerative changes in the muscle fibers, and here you can see a conglomerate of autophagosomes and lysosomes here, and this is autophagic vacuole here with a lot of debris and material that is not broken down. And this is part of what we see in Pompe disease, these autophagic vacuoles. Type 3 glycogen storage disease is also called Cori disease, debrancher enzyme deficiency. This is also a vacuolar myopathy, where you can see sometimes very large vacuoles. And if you do a PAS staining, these vacuoles are filled with PAS positive material. And there are also other degenerative changes, and you can see here, this picture here, the severe atrophy, and there's increased interstitial connective tissue. And eventually there's a severe atrophy, and the storage material is normal glycogen, which you can see in large lakes in the muscle fibers. This is an atrophic muscle fiber, an electron micrograph. Eventually the muscle will be more and more atrophic, and in this case you can see a severe fatty replacement in the muscle, and a few muscle fibers are preserved, others are severely atrophic, and a lot of connective tissue and fat tissue. So as in several glycogen storage diseases, there is either exercise intolerance or more fixed muscle weakness, but in many cases there is a mixture of that. Type 4 is the branching enzyme deficiency. So this is an enzyme that is involved in the glycogen synthesis. This is type 4, and this is a disease that comes in many different forms. So what is called a typical form is a liver disease and later onset with myopathy. And these patients often have a liver failure and needs transplantation. But then there are also more pure neuromuscular forms, which may come very early as perinatal, very severe with arthrogryposis, fetal hydrops, and so forth, and congenital infantile and juvenile. And then there is the adult polyglucosan body disease in the end here. So there are many different types of branching enzyme deficiency diseases. But from a muscle point of view, the interesting thing is that you have accumulation of polyglucosan in the tissue, and that is seen as PAS positive, rather sharply demarcated inclusions, as you can see in many fibers here. And many of these fibers seem to have a low amount of glycogen, except from the storage material. You can also see the storage in the H&E as unstained inclusions. If you do the amylase treatment, these inclusions will remain undigested. So this is one of the definitions for polyglucosan. So these are diastase resistant inclusions. And on an electron microscopy, you will see these. This is the edge of a muscle fiber on an electron microscope, and this entire part here, down here, is polyglucosan, and it looks a little variable in different parts, more dense inclusions. Others are less dense, and you can more clearly see a fibrillar structure here. And here to the left is another part with the inclusion. I will show you also what may happen in the very severe cases. So this is from a perinatal case who died early, and you can see that to the left the H&E staining shows a very severe degeneration and fibrosis, and a lot of inclusions that are seen in H&E here, and they are PAS positive. And if you look in polarized light, as you do with amyloid, when you have Congo staining for amyloid, you look in polarized light to see the birefringence. But these are naturally birefringent, these inclusions in this perinatal form. And some of these inclusions are very dense, and you cannot really identify really fibrillar structure. Others are more fibrillar. And to the left here you can see small muscle fiber, and you can see dense inclusions here, and you can see also autophagic vacuoles here with material that is not digested. So this is one of the most severe forms of branching enzyme deficiency. So the next disease is the McArdle disease, which is one of the more common glycogen storage diseases, and this is a disease mainly showing exercise intolerance, but eventually more fixed muscle weakness can occur with increasing age. And these patients show usually glycogen accumulation. So it's another vacuolar myopathy with subsarcolemmal vacuoles, as you can see in the H&E staining here. And these are filled with glycogen that looks normal if you look in the electron microscope. Sometimes it can be quite difficult to find this glycogen accumulation, as in several of these glycogen storage diseases. It's not always so obvious. And in these cases, and in many labs, staining for the myophosphorylase is done as a part of the routine stainings, because this will, if you have McArdle disease, you will see a deficiency of the myophosphorylase, as seen to the left here, and this is control. And sometimes you can see necrotic muscle fibers, or more frequently regenerating muscle fibers. And these show a positive staining for myophosphorylase, because this is another isoform than the mutated one, which is then the muscle fibers mature, they will change to the mature myophosphorylase isoform and lose this activity. The type 7 glycogen storage disease is phosphofructokinase, and this is another exercise intolerance glycogen storage disease, but also with muscle weakness and some other features. And this is a vacuolar myopathy again, and you can see these vacuoles in H&E, and they look kind of empty in these stainings. Also NADH TR staining, you can see these subsarcolemmal vacuoles. But they are in fact filled with glycogen, and this is done in this staining, in this case, is done on resin embedded material. So in this case, or in this specimen, the material was fixed for electron microscopy and embedded in resin and stained with PAS. And this is a good method really to identify the glycogen storage. At least in our lab, sometimes the glycogen in larger lakes, they kind of disappear from the sections during preparation. And but with this method, the glycogen is much better preserved in the tissue. So this can be a good thing to think about if you want to know what the vacuoles actually contain, to do electron microscopy and also stain the semi-thin sections that are resin embedded with PAS. So again, this is normal glycogen that is present in phosphofructokinase deficiency. Then there is a group of glycogen storage diseases that are even more rare, and there's a list here from 9 to 14, and most of these are associated with exercise intolerance, but they can have more severe episodes with myoglobinuria and rhabdomyolysis. But there are two of these that I would like to mention, and what I should add that in many of these cases the amount of glycogen that is stored may be very small and difficult to identify. Sometimes it can be more obvious. But one of them is the phosphoglycerate mutase deficiency, which in many cases is associated with tubular aggregates that you can easily identify on NADH-TR staining as dark, well demarcated inclusions, mainly in type 2 fibers, and they are stained red in Gomori trichrome. And of course you can see these tubular aggregates on electron microscopy. So these patients also show some glycogen accumulation, but again, it may be difficult to be completely sure you have a glycogen storage disease. But this is a possibility to identify. It's not a finding that you see in every case, but in many cases, these tubular aggregates have been described. Of course, not a specific finding, but can give a hint if you have other signs of clinical signs of the possibility of phosphoglycerate mutase deficiency. Another interesting disease in this context is the phosphoglucomutase 1 deficiency, because this comes as a more typical glycogen storage disease with exercise intolerance, cramps and myoglobinuria, but many cases have been described as CDG syndrome, a congenital disorder of glycosylation, which is a big group of diseases where you have glycosylation defects in many organs, and this gene or this enzyme is linked to this kind of diseases with more severe and generalized symptoms with malformations, hormone deficiency, cardiomyopathy, and etc. So these diseases are very, very uncommon, and this is one of the cases we have seen, which really minor alterations in the muscle and only some glycogen storage here. But these are all very rare disorders, most of them at least. And again, there is cytoplasmic storage of normal glycogen in the muscle fibers. Now I will turn to type 15, which is glycogen 1 deficiency. And glycogen 1 is the core protein in the glycogen particles, and it's seen here in a schematic illustration. So glycogen 1 functions as a primer for glycogen synthesis. So it forms a short chain of glucose molecules, and then glycogen synthase and branching enzyme will add on and continue with elongation of these chains and branching of these chains by the branching enzyme, and you will end up with a large glycogen granules that you can also see in the electron microscope. So glycogen 1 deficiency has two different names in OMIM. So it's a type 15 glycogen storage disease, and also a polyglucosan body myopathy disease type 2. And initially, glycogen 1 deficiency was described as a cardiomyopathy, and muscle tissue in this initial or first case showed really deficiency of glycogen in the skeletal muscle, whereas there was accumulation of glycogen, or in fact polyglucosan, in the myocardial cells. You can see in the central part of every cardiomyocyte you see this accumulation. This is the normal heart. This patient eventually had a transplantation, and 11 years later, and also after the transplantation, muscle biopsy still lacked glycogen, except for a few fibers that looked normal, but no polyglucosan in this patient skeletal muscle. But then it became apparent there were also other cases with this cardiomyopathy type of glycogen deficiency, but these showed not this deficiency of glycogen. So this seems to be unique to this particular patient. So the other patients had normal glycogen or some polyglucosan inclusions in the muscle fibers. The other form of glycogen deficiency is a disease that mainly affects the muscle. So these patients usually don't have any cardiomyopathy, and then they show instead accumulation of polyglucosan, this amylase resistant material that you can see to the right here. And so this is a polyglucosan body myopathy, and this is why it got this name, polyglucosan body myopathy type 2. This is much more frequent than the cardiomyopathy type. But again, this is a rare disorder. And this has some peculiarities that are common to all polyglucosan body myopathies, that these inclusions are stained with some antibodies. For example, antibodies to P62 that you see often in myopathies with autophagic vacuoles like inclusion body myositis and some distal myopathies. But in these cases, the entire inclusions are stained with for P62, as you can see here. So that's a very good method to use, and we do P62 staining as a routine staining in all cases, because it's very helpful in many instances. But interestingly, these inclusions also stain for desmin, which is difficult to understand, but they also contain a lot of other proteins and enzymes, especially enzymes that are associated with glycogen metabolism. They are kind of stuck here in these inclusions. So this polyglucosan in glycogen deficiency is seen as fibrillar material, and sometimes you see some kind of abnormal glycogen also. And although the material is amylase resistant, it's not completely resistant. So it depends a little on how you do your amylase treatment, and you should be careful not to treat too intensely and for a too long time. Because then it will all disappear in most cases of glycogen-1 deficiency. Another polyglucosan body myopathy is the polyglucosan body myopathy type 1, which is caused by mutations in a gene called RBCK1, which is a what you call ubiquitin ligase, and in this disorder you have muscle weakness, but also cardiomyopathy, and autoinflammation and immunodeficiency can occur in more severe cases. But it looks very much like the glycogen deficiency with these polyglucosan inclusions that you see in these fibers here, and this is much more resistant also to amylase treatment, which you can see here. And again, these inclusions are stained for P62 and looks rather similar as a glycogen 1 deficiency with this polyglucosan inclusions you can see here to the left and at a higher magnification here. So it's kind of fibrillar. And the fibrillar appearance is probably because the length of the unbranched chains are longer than in normal glycogen, which makes it more insoluble, and this is why it aggregates and form this polyglucosan. And the typical example is, of course, branching enzyme deficiency, where there is no branching of the glucose chains in the glycogen. So I would like to summarize the polyglucosan storage myopathy, because this is something that you can see in the microscope, that you have a polyglucosan storage myopathy, because it looks so typical with these dense PAS positive inclusions that are amylase resistant. So I have mentioned branching enzyme deficiency and RBCK1 deficiency and glycogen-1 deficiency, and they look very much alike, as you can see here. And these enzymes are involved in glycogen synthesis, or like branching enzyme and glycogenin, or RBCK1 is involved in glycogen metabolism. Exactly how is not clear, but it's a ubiquitin ligase that is ligating with glycogen, and but exact mechanism for this is not known. But then there is also Lafora disease, which also affects muscle. It's a brain disorder, a very severe brain disorder, where a lot of polyglucosan in the brain. But these enzymes, two of them that cause Lafora disease, they are directly involved in glycogen turnover and metabolism. So, and then there is a special form of polyglucosan body myopathy in horses, and that is caused by a gain of function mutation in glycogen synthesis, glycogen synthase type 1. This is not the type 0, this is a gain of function in a specific mutation in horses, and they have this polyglucosan storage. So there is an imbalance between this case between branching enzyme and glycogen synthase, making this unbranched glucose chains in glycogen, which precipitates and form aggregates. And then there are some polyglucosan storage disorders that affect only heart, and the mechanism for this is not known. And phosphofructokinase, the muscle isoform, can sometimes show muscle fibers with polyglucosan, but this is not in every case. But then there is a new version. It's not completely new, but it was described 2021. And this is another polyglucosan body myopathy, but with multisystem involvement. And like RBCK1, you can have brain involvement, autoinflammation. But this has been called by OMIN as a combined oxidative phosphorylation deficiency number 53. But it has some similarities really with RBCK1 deficiency, with this polyglucosan storage in muscle, which you can see on the electron micrograph, and these P62 positive inclusions in the muscle fibers. But they have some mitochondrial respiratory chain defects also, and this is why they are classified in this. It is not exactly known what this gene does, so it has not been, the pathogenesis is not completely clarified. So now I will turn to the lipid storage myopathies, which are also really rare disorders. And I have put this table here from this article, the review article, just to show you how many enzymes there are in lipid metabolism that may cause, in some cases, then lipid storage. And in many of these cases, a myopathy can be present, but there are also other, organs or systems that are affected, and many patients with these lipid myopathies have fasting hypoglycemia, and many can have a cardiomyopathy or hepatopathy. So I'm not going to go through all these very rare disorders, but I will speak more in general and mention a few. And so lipid myopathies can manifest with systemic illness and muscle involvement. And systemic illness, I mean, this is episodes with hypoglycemia and maybe severe muscle involvement with muscle weakness and rhabdomyolysis in an episodic way. But in some diseases, there is a more fixed muscle weakness. And some of these then also show a more constant lipid accumulation. So, and these are a primary carnitine deficiency, a neutral lipid storage disease, and MADD. I've pointed here to these with the red arrows here in the kind of difficult pathways of fatty acid metabolism, as you can see here. But I mean, from a general point of view, the fatty acids enter into the cytoplasm, and they are labeled with carnitine, and then they are imported into the mitochondria by carnitine palmitoyltransferase 1 and 2, and then they enter the beta oxidation, and eventually these metabolites here, they feed the respiratory chain here at the bottom with NADH and FADH. So, and there are many enzymes in these pathways that then can cause these lipid myopathies. But and these are more what you see in the muscle biopsy, because most of them can show lipid storage, but not. Maybe you are more lucky to find it if you have a biopsy during an attack than if you do it between these occasions with energy failure. So, and then sertraline, which is an antidepressant drug, is also associated with lipid storage in some cases. And this I will also talk about. And CPT2 is not so uncommon, I mean, among these uncommon disorders. And this is associated with rhabdomyolysis, but only sometimes lipid storage can be identified in these cases. And beta oxidation defects, all these that are involved in the metabolism of the fatty acids, they sometimes show muscle lipid accumulation, but this is not a consistent finding either. And then other disorders that show lipid storage in at least some muscle fibers are mitochondrial disorders, the respiratory chain defects, so-called mitochondrial myopathies. In most ragged red fibers, which you see in mitochondrial myopathy, you will find an abnormal amount of lipids. And in my experience, at least, in many inflammatory myopathy, you will see lots of fibers with lipid accumulation, but not in all fibers. And when we talk about lipid accumulation and lipid storage, it's these lipid droplets that you normally see in muscle fibers that are increased in amounts and in size. So I will show you the examples of these where you invariably find lipid storage. So this is primary carnitine deficiency, and it's in fact a disease caused by a defect of the transporter of carnitine, and this causes a deficient import of long fatty acids because there is no carnitine into the mitochondria, and then it accumulates in the muscle fibers. And this is typically associated with childhood onset myopathy and cardiomyopathy. The good thing is that it can be treated with L-carnitine. So this is from one such case, a child with a cardiomyopathy that was more or less cured with treatment with L-carnitine. And what you see here is sodium black staining, where you can see enlarged lipid droplets in almost every fiber. I mean, some of these fibers may look more normal, but most of the fibers have an abnormal accumulation. And this is a longitudinal section of muscle fibers embedded in resin for electron microscopy, and you can here see the long rows of lipid storage in the intermyofibrillar space, because what we see here is a longitudinal section of two fibers. So this is diameter of one fiber, and this is another fiber here, and this is the lipid accumulation here. So another lipid storage disease is neutral lipid storage disease, and this is usually due to variants in the PNPLA2 gene, which encodes for ATGL, the triglyceride lipase enzyme. And there's a defect hydrolysis of the triglycerides in the lipid droplets, so what enters the lipid droplets cannot be removed from there. And this is a childhood or young adulthood onset disease with muscle weakness, fixed muscle weakness that is progressive. And this is one such case. And you see here the vacuoles that you can see with the sodium black here are filled with with lipids stained with a sodium black staining, and they're also called rimmed vacuoles, and so autophagocytosis ongoing here, and P62 positive material, which is typical for this disease. And well, what else? Can see here a lot of vacuoles in different fibers. In this case, there's a type 1 fiber predominance. And then another disease that usually show lipid accumulation is MADD, multiple acyl-CoA dehydrogenase deficiency, usually due to variants in the ETFDH gene. And this is an enzyme that transfer electrons from the beta oxidation to the respiratory chain. This is from a 25-year-old man with a progressive muscle weakness, somewhat fluctuating, and he was diagnosed with MADD based on increased levels of acylcarnitins, which is a common method to diagnose lipid myopathies or lipid deficiency in metabolism of the lipids, because you have an increased accumulation of acylcarnitins in blood that can be measured with mass spectrometry. And they have rather specific, in fact, pattern, these acylcarnitins, with different lengths of the acylcarnitin that you identify with mass spectrometry. So this he was identified in this way, and he was treated with riboflavin and got much better. So it's riboflavin responsive in many cases, this MADD. And you can see here the lipid storage shown here. It's not so severe, but you can see it here as lipid droplets stained with sodium black. And here is the ATPase staining for different muscle fiber types, and you can see it's good staining to see the droplets, actually, because they are much more visible in this staining than the H&E staining, where you can hardly see that there are small vacuoles, but there are. But of course, a lipid staining is always good to do, to be sure what you see. It's not only artifacts, these small holes that you see in the muscle fibers. So I will now turn to a more recent disease that, from our perspective, and I think this is also in the entire Sweden, that this is much more common than any other lipid storage disease that we have seen. And this is an adult onset lipid storage myopathy, which show rather severe lipid storage. And these patients have either carnitin deficiency or MADD-like acylcarnitin profile in blood. And they are treated with sertraline, usually for depression. And these have been treated for weeks or months or years when they develop this muscle weakness. And it's often axial weakness, proximal muscle weakness, neck weakness with dropped head, several of them. And this was recently published by a Swedish group in Linköping. And we have also now looked in our material and identified 11 other cases. They had a series of 7 cases here, and we looked at 11 patients, and so they don't have any ETFDH or other genetic defects that can explain the lipid storage as far as we understand, but they are all on sertraline treatment. And they are riboflavin responsive, some of them, and they can be better if you stop the treatment. But this is to be followed up more thoroughly, I think. An interesting thing is that here you can see different fiber types, and you can see the blue fibers are type 1 fibers, and they are more affected than the type 2 fibers, which are green or red, type 2A and B, but there were no type 2B fibers in this case. And this is control where you can see the type 2B fibers. But these show rather pale staining when you stain for cytochrome C oxidase enzyme histochemistry or succinate dehydrogenase enzyme histochemistry. So we have looked more thoroughly into the mitochondria, and electron microscopy in these cases show a mitochondrial proliferation that is quite obvious in most cases, I would say, at least those with more severe lipid accumulation, and they also show frequently inclusions in the dark round inclusions in the mitochondria, and the mitochondria are also unusually dense in their matrix, I think, from what we are used to see. So this is a feature that most of them show, is this dense matrix and mitochondrial proliferation. And then they also they show this complex 4 and complex 2 deficiency on enzyme histochemistry. And when we look with a method to look more at the protein levels for using antibodies to complex 1, complex 2, 4, we see a deficiency of mainly complex 1, in fact. So it's not a severe deficiency of complex 2 or 4, but mainly of complex 1. And so these are controls here, and this is complex 1 immunofluorescence for complex 1. You can see few fibers that are normal, but many of them seem to be rather deficient of complex 1. Complex 2 also deficient, but not to that extent as complex 1. And also I don't show the complex 4, but it looks like complex 2 more or less. And this is the VDAC1 is the mitochondrial staining. You can see the mitochondrial proliferation here compared to a normal control. So there's respiratory chain deficiency, and if you mixed all these, you can see the complete difference in color from the control, because you have lack of the green, to some extent lack of the red, and increased amount of the mitochondria that are blue and ends up in this. So this is a consistent finding in all our cases, especially the complex 1 deficiency. And that was my message for today. So I'm happy to discuss with you any aspects. Thank you.
So thank you very much, Anders. This was amazing. The images are fantastic, and this last condition that you showed us, it's very interesting, because in terms of frequency, there are many patients that are under sertraline, and so I think that these patients should be carefully examined and also maybe undergo to a muscle biopsy in order to detect this condition and probably try to cure with riboflavin. I would like to know if the mitochondrial dysfunction that you found was associated with a specific enzymatic deficit of the complex 1 on the respiratory chain. Did you study exactly? And also, did you study if there was an alteration on the assembly, for example, of the complex 1?
Now, what we have studied, we have not done the biochemical investigations. From our 11 patients, or archival material from 2015 and onwards, and we had no. From the beginning, I mean, we thought this was just a lipid storage myopathy. And we did not do any extended mitochondrial investigations, because then we would have had to do another biopsy to do the biochemical investigations. And they were all having a MADD profile, and they were considered to have MADD. And later, they have been investigated more thoroughly also from a genetic point of view, and they had no mutation. So the biochemical investigations have not been performed in these cases. Only one case were investigated with a second follow-up biopsy, and when he had but then he had been out, had not been on sertraline for more than half a year, and we did not find any specific changes then in his muscle. So we have no experience of respiratory chain investigations in the way that we do them, because the way we do them in Gothenburg, the respiratory chain is open biopsy, and we isolate the fresh mitochondria, and we do polarography, that is oximetry of the fresh mitochondria, to be sure that we are in fact analyzing the function of the oxidative phosphorylation. So it's a direct method, and that we also combine with the enzyme measurements of cytochrome C oxidase, etc. But
Thank you.
we need a big biopsy, and this was not done in these patients. So what we did was proteomic analysis of all the proteins then, and we found that in all patients, all the complex 1 subunits were downregulated. All
Great.
complex 1 subunits in the proteomic analysis.
Yeah, thank you very much. We will go on because there are questions. In particular, there is one question live. So maybe the person who would like to ask the question can go on. So is Julia Taman? Can you show up? Thank you. In the meanwhile, there are many comments about the excellence of this talk. So congratulations, Anders. So we have Julia. Can you speak up, please? Okay. So Werner, you are second in line. As we have a limited time, you can go on.
Okay. Can you hear me?
Yes, perfectly.
Yes.
Okay, so I have two questions. One is, do the sertraline-induced MADD patients also are they triggered by fasting?
But this is a difficult question. What is the trigger? And it seems there must be something, but probably there are many different triggers, and I guess that, like in other MADD cases, there are triggers, including, alcohol and fasting and illness of different kinds. So there must be additional factors, and there may be additional genetic factors also.
Yeah, that is concerning my second question. We have two cases it's probably a genetic question. We have two cases where we found only one mutation, and I think I also talked with somebody who said, yes, it's more frequent than in other recessive diseases that people find only one mutation. Is this also your experience?
Well, we have no such case in our material, but this has been mentioned. But on the other hand, recessive mutations, then you have to have a large material really to compare this. You cannot blame this isolated recessive mutation, but it's possible that it increases the vulnerability. It's quite possible, but I don't think it's proven yet.
Thank you.
So then we have a technical question from Tirin Luliok, Mayo Clinic. Do you prefer Sudan Black or Oro, red oil?
Well, I would say I would prefer oro. I think I will go back to that, but we usually do the pseudo black. For a while we did both, but then for illustrations in black and white, if you go back, in history, for some years, pseudo black was more easy to illustrate in black and white, and so this was the reason. I don't think there is any real difference in the technique. I mean, from a practical point of view.
Okay, thank you. Next question from Neringa Valtiene. Could sarcopenia cause straight angular pseudo-vacuolization appearance of the fiber with more or less accumulation of glycogen?
Well, sarcopenia.
Yeah, yeah. If sarcopenia cause pseudo-vacuolization appearance.
I don't know. We really the literature on sarcopenia is there's a huge literature, but I haven't really got into that very much. This is not what we are dealing with really, because sarcopenia is age-related atrophy of muscle, more or less. I mean, and decreased strength, and there is so many hypotheses what is going on in sarcopenia. And I couldn't answer this question if one see that, but I haven't seen it published at least. But well, I don't follow the sarcopenia literature very much.
Okay, thank you very much. Next question from Grace McMacken. Why is sertraline specifically associated with lipid storage myopathy? Could other SSRIs be associated also?
And no, it seems not. I mean, so far, but eventually, I think when people dig into this more, we'll find more things. But it seems not to be the case. So it's sertraline.
Specifically sertraline. So
Yes, in general, yes, it seems to be. Yes.
okay, and then we have for how long patients should be on sertraline to be at risk to develop this specific myopathy, or is more about the dose?
There may be a combination. I think this is not studied well enough. You cannot say, but because in the other study I mentioned about from Linköping, 7 patients, they could see no clear correlation, but maybe some patients that had developed muscle weakness had increased their dose, and so they thought that could be an explanation, but this has not been the case at all in our material 11. And some have been on sertraline for a shorter period, like a few months, other for several years. So a long time span. But and also, if you have an insidious onset, it's difficult to tell exactly when it started. If you have many other problems also, so maybe it has to be a rather severe muscle weakness, I guess, before you go to the doctor if you have many other problems. Difficult to say, really.
Yeah. The question maybe is, should we try to see if there is some genetic predisposition for this kind of susceptibility, as sertraline is widespreadly used in the...
Yes. So this is has been discussed now how to proceed with that, because you need a large material, I think, to get to any conclusions. We looked into it a little bit, but didn't find any things that we could be sure about.
Okay, there is a theory who is saying that they have seen lipid storage myopathy with ranolazine. Do we have similar cases?
No, not that I can recall directly. Do you?
Personally, not.
No.
Thank you very much. I think that there is no more question. We have 1 minute before the end of the session. So I would like to congratulate you for this illuminating and fantastic webinar with magnificent images. and we will meet in 1 week for the next webinar. Thank you very much. Bye-bye.
Thank you all. Bye bye.